I just want to say what a pleasure it is to be able to be here in Vancouver and have the chance to meet and talk with so many people that are really engaged in trying to improve the healthcare system here. So I promise not to dance. But I do want to talk this evening a little bit about what I call the promise of Medicare. And I want to share with you 3 big ideas that I think can help us to fulfill that promise. So to begin, I guess we'd better define what exactly is the promise of Medicare. For starters, it has to do with living our values, specifically the value of equity of access to healthcare services. Put simply, Canadians believe that access to healthcare should be based on need, not ability to pay. But Medicare binds us together in more ways than just by delivering health outcomes. It strengthens our economy, it improves our social stability, and very importantly, it gives us an example that we can point to of what our nation stands for. And I do think that that is why so many people watched that YouTube clip, is because it tapped into some of that pride about the fundamental premise that underpins our healthcare system. From coast to coast, as Canadian Doctors for Medicare has said, it is seen as the highest expression of Canadians caring for one another. So to me, that's the dual promise of Medicare: to deliver accessible, high-quality healthcare services in an equitable way, and to give us something we can be proud of. Which means that when we think about improving Medicare, we need to think not only about how do you improve the delivery of healthcare services in an equitable way, which is frankly hard enough, but also we have to think about how do you make a social program worthy of iconic status. And there are lots of ideas out there about how we can do that. So the question is, how do we choose? How do we pick which ones to try to advance? And I think that there is really only one thing that can help us to resolve the inevitable clash of ideologies, and that is evidence. We cannot build our system on ideas that sound good or seem to make sense. We have to be willing to examine all the available data here and internationally to try to separate fact from fiction and failure from success. So to illustrate this, the importance of evidence in framing this conversation, I want to begin this evening by looking briefly at 3 critical elements of the Canadian healthcare system: cost, quality, and access, and point out some important realities that I think frame the big ideas that I want to share with you tonight. So first, cost. We spend a lot on healthcare in Canada, 11.2% of our GDP last year, and that puts us in line with other OECD nations, but in the top third. But unlike most of our comparator countries, the proportion of that spending that is public is actually near the bottom. And this is something that I think many Canadians don't realize because we always compare our healthcare system to the United States. In fact, for every dollar that we spend on healthcare in Canada, 70 cents is public. In France, that number is 77. In Norway, it's 86. We spend a lot of money on private insurance and out-of-pocket on services that are not covered by Medicare, such as prescription medications and dental care, and those numbers are increasing. A recent study by Statistics Canada found that since 1998, our average out-of-pocket health expenditures have been rising by 3% per year on top of inflation. But what we spend may not matter so much if we're getting good value for money. I mean, absolute dollars doesn't speak to what we're getting for what we spend. And on many measures of healthcare quality, I would say we do reasonably well. Canadians report very high levels of satisfaction with the quality of our healthcare, with 71% giving good or very good ratings to the healthcare our families receive. And our health outcomes are quite consistent with that perception. Our average life expectancy is 81 years, which is a year ahead of the OECD average. Our infant mortality rates are lower than the average. We rank 4th out of 16 peer countries on mortality due to circulatory diseases like heart attacks and strokes, which are a leading cause of death in Canada. So this sounds pretty good, but let's be honest, there are places where we really need to improve. For example, 1 in every 12 hospitalized patients in Canada is readmitted to the hospital within 30 days of discharge. And 1 in every 10 patients discharged from hospital is seen in the emergency department within a week of leaving hospital. Too often, sick Canadians cycle in and out of the hospital, receiving treatment from different providers who don't coordinate and don't communicate. And I suspect that many of you, as healthcare providers or family members or in your own experience, have witnessed that phenomenon up close. But of course, the controversy about healthcare in Canada and whether Medicare really delivers the goods isn't really about cost or quality. It's about access. By and large, our system does a terrific job of delivering when people are seriously ill, and I think most of us are prepared to accept some amount of waiting in a system where we know that everyone has access. But the reality is that we still have a lot of work to do to reduce wait times in Canada for non-urgent medical care. A 2010 Commonwealth Fund study of 11 countries found that only 22% of Canadians can see their family doctor on the day they call for an appointment or the following day, which puts us well toward the bottom of the list of G7 countries. As the same survey placed us second last on wait times exceeding 4 months for elective and non-emergency surgery. Only the UK was worse. And British Columbia is among the provinces that's taking a lead in trying to remedy this problem by working to make sure that everybody has a family doctor and by stepping up measurement on wait times. All of that is a good start. But unfortunately, the problem is ongoing. The Wait Time Alliance gave BC a grade of B for achieving benchmark times for hip replacements, not so bad, but a grade of C for knee replacements, not so good. And when I teach healthcare policy to the residents at the University of Toronto, B is the general grade that I give our healthcare system on quality. Not so bad, not so perfect. So in the areas of cost, quality, and access, the evidence is clear. We have much to be proud of, and we have a lot of work to do. In scanning the policy environment, I see 3 big ideas out there that I think would truly raise the bar for Canadians' health in the next decade and help us to address these challenges of cost, quality, and access. I want to be clear that they're not my ideas, but they are well formulated. They are based in good evidence, and in my view, they meet the 2 key tests for delivering on the promise of Medicare. They would improve equity of health outcomes, and they are worthy of an iconic program. So tonight, with gratitude to the innovative thinkers who continue to develop new ways to improve our system, I want to dedicate these 3 ideas to 3 Canadian patients, because I think it's important that we remember who we're in this for. So here comes idea number 1, 20 drugs to save a nation. We don't need to look south of the border to find healthcare that's inequitable, costly, and inefficient. An honest assessment of our approach to paying for prescription medications in Canada reveals a sorry state of affairs. At the time that Medicare was developed in the 1950s and 60s, and even into the 1980s with the passage of the Canada Health Act, the bulk of healthcare was delivered by doctors and in hospitals, which meant that our public healthcare system actually covered nearly all drugs because nearly all drugs were given to patients when they were in the hospital. But today, it's a completely different picture. Our systems are rapidly transforming to meet the needs of an aging population, and we have a population that's living longer with chronic disease, and not doing so in hospitals, but in the community, which is where most of us would prefer to get our care. And let's be honest that one of the mainstays of treating chronic disease in the 21st century is prescription medicine. I'm not sure if you're aware that Canada is the only developed country in the world that has a universal healthcare insurance model where that insurance does not cover prescription drugs. And the result is that 1 in 10 Canadians does not fill a prescription or take their medication as prescribed because of concerns about costs. That number, by the way, I know that, that there's a lot of debate about the program that you have in British Columbia. In fact, BC has the highest rate of medication non-adherence, or people not taking their meds because of costs. That number is 17% here in BC, the highest in the country. So I'm dedicating idea number 1 to a patient in my own practice who we'll call Ahmed. Ahmed is a taxi driver of South Asian heritage. He lives in downtown Toronto with his wife and 3 beautiful kids, and he works long shifts behind the wheel. This, by the way, in spite of his university education and his perfect English. Like so many taxi drivers, his genetic heritage and his sedentary job have predisposed him to his medical problems of diabetes, high cholesterol, and high blood pressure. Although he and his wife are careful in their spending, he simply cannot support his family and pay for his medically necessary medications, which cost hundreds of dollars per month. And even if he could figure out Ontario's complicated catastrophic drug coverage plan, he can't afford the deductible. So sometimes I just don't see him for long periods of time. And when that happens, I know that it's because he isn't taking his medicine and he doesn't want to disappoint me. I worry, as he does, about the complications he may experience in the coming decades, some of which could be devastating, such as heart attacks, strokes, and blindness, because he cannot afford to both feed his family and pay for his medications. The most obvious way to fix this problem would be to bring all prescription drugs under Medicare, just as we've done for doctors and hospitals. But if we can't summon the political will to do that right away, let's focus first on those prescription medications that give us our biggest bang for the buck. Let's choose 20 or 50 or 100. You pick the number. Medications that are commonly used to control chronic diseases like asthma, diabetes, and high blood pressure. If we can agree nationally to go in on public coverage for those medications, we can cover them for everyone, including Ahmed. And if we did this, we would actually end up spending less publicly than we currently do. There are two major reasons for this. First, you may not realize that in Canada, we pay much higher prices for drugs than many other healthcare systems do, especially for generic drugs. If we could negotiate prices like the ones that are paid in other developed countries, we could easily cover the cost of 20 drugs to save a nation within our current public budgets. Just to give you an example, here in BC, 10 milligrams, a single 10 milligram pill of the cholesterol-lowering medication simvastatin currently goes for 36 cents. The exact same pill costs less than a penny in New Zealand. This is in spite of the fact that BC has been a national leader in terms of pushing down the price of generics. If we bargained more effectively together across the country, the prices for the drugs that we already buy publicly, for example, for all seniors and people on social assistance, would go down. Second, other systems achieve these huge savings by bulk buying their prescription drugs on a large scale. So just as we all know, you save your money on toilet paper if you buy those big things with 36 rolls in them, the same thing goes for medications. When you consolidate your purchasing power, you can get much better value for money. Between our public plans and our private plans, in Canada, we literally have dozens of purchasers of the same set of prescription medications. We would do much better with just one. Reforming our public insurance to include medicines is something that our public officials can do. But the rest of us, and I know there are lots of healthcare providers in the audience tonight, have a big role to play in fixing Medicare too. As providers, administrators, patients, and citizens, we need to roll up our sleeves and get to work on idea number 2, a concept I'm calling doing more with less. Doing more with less is about improving access to healthcare for Canadians who need it by reorganizing the way that services are delivered to people. It's not a single policy that can be implemented by passing a law. It represents a shift in our thinking, away from the presumption that the answer to our challenges in healthcare is always more. More money, more doctors, more tests, more machines, more procedures, an approach that has plagued the healthcare system for far too long. Instead, we need to start taking the resources available to us, and there are lots of them, and using them more intelligently. This means that where wait times are long, we don't immediately try to hire more surgeons or open more operating rooms. Instead, we ask 2 questions. First, will everybody on the wait list actually benefit from the proposed test or procedure? And second, where is the bottleneck causing the wait? Can we organize care better to improve the flow of patients through the system without spending more? So the first question, the question of whether the test or treatment will actually benefit the patient, probably sounds silly to some of you. You're thinking, of course it would benefit them, otherwise the doctor wouldn't have ordered it. Sadly, that's not always true. To illustrate this principle, I want to tell you about a patient we will call Sam, who came under the care of a cardiologist colleague of mine. Sam was a perfectly healthy man in his 60s. He didn't smoke, he didn't drink, he didn't take any medications. In fact, he was a world-ranked athlete in a competitive sport. As part of his compensation package at a fancy downtown firm on Bay Street in Toronto, he went every year for an executive physical at a private clinic. One year, in spite of the fact that he felt perfectly well, he was subjected to an exercise stress test, just in case. Some potential abnormalities were identified. So in the end, he was sent for an angiogram, which is an invasive test that looks to see if there is significant blockage around the vessels of the heart. Happily, the angiogram confirmed that Sam did not have heart disease, but not before he suffered a stroke on the table, a known complication of the procedure that occurs in approximately 1 in every 1,000 cases. This healthy athlete will never play his sport again because he's paralyzed on one side of his body as a direct result of a completely unnecessary and inappropriate test. So I know some of you are thinking, I have this debate with my partner all the time, but what if they'd found something? And wondering if the risks might not be worth it to pick up that one cancer or that one case of undiagnosed heart condition. But that's exactly the point. We need to stop thinking only about benefits, and we need to start talking about harm. Friends, millions of Canadians are harmed every year by inappropriate, wasteful, and harmful tests and prescriptions. Radiologists agree, for example, that up to 30% of imaging scans do not contribute any useful information to the management of the patient's condition, and many of those scans involve radiation. To give you a sense of the impact, it's estimated that the quantity of excess radiation exposure from CT scans could cause the equivalent of 14,000 cancer deaths every year in the United States. Furthermore, eliminating useless and inappropriate CT and MRI scanning would make a huge dent in our wait times for these important diagnostic tests for people who actually need them. It's for this reason that Canadian physicians are following the lead of our American counterparts and have launched a national campaign called Choosing Wisely Canada. As part of this campaign, medical societies across Canada are developing lists of the top 5 things that physicians and patients should question. The second question we ask when we try to do more with less is whether the bottleneck causing the wait can be alleviated using creative approaches to get us better value for money. So I'm going to explain what I mean here using an example. When I first started practice a decade ago, if I had a patient who needed a knee replacement, I would refer them to the orthopedic surgeon whose name I could remember. And that person kept his wait list in the top drawer of his secretary's desk. And if he went on vacation for the month of August, the wait list just got longer. And if there were other surgeons who had longer wait times, I had no way of knowing that. In fact, he could have a new graduate working in the office next door to him who had 0 wait time, and he could have a 2-year wait list, and I wouldn't have any way of knowing that that was the case. Since that time, part of the concerted effort to reduce wait times in Ontario has included the introduction of centralized intake and assessment centers across the province. So now, when I refer a patient with late-stage osteoarthritis of the knee, that person is seen within a week or 2, not by a surgeon, by an advanced practice nurse practitioner and a physiotherapist. These highly trained professionals educate my patient about the nature of the disease, teach them exercises to improve their preoperative strength, counsel them on the importance of weight loss, and apply an evidence-based checklist to determine whether or not my patient is actually even a candidate for surgery. If they are a candidate for surgery, the patient is then offered a choice to either wait for the surgeon of their choosing or to see the next available surgeon. Using a very similar model of centralized intake in the public system, the Richmond Hospital Hip and Knee Reconstruction Project here in BC has reduced waits for artificial joint replacements down from 19 months to 7 months. That's probably still too long, but it's a remarkable improvement. Centralized intake is a key theme arising in successful projects on weight. So I'd like to illustrate this important point by giving you an example. At 6 o'clock at night when I'm rushing home to get to feed my 5-year-old dinner, I stop at the grocery store, I grab whatever I need, and I head for the checkout line. And then I start the guessing game. You all know this, right? Which line do I choose? If I get into this one, if I choose the right line, I'm home in 12 minutes. If I choose the wrong line and it's a trainee or there's somebody counting out their change in front of me, it's going to take me half an hour to get home. Now, if I make the same stop at the bank, I get in a single line, one line, and I'm served by the next available teller. The banks have figured out the beauty of applied queuing theory. The grocery stores have not. When you pick up dinner tomorrow, you can see this in action for yourself. By instituting a single common queue, we have dramatically improved the flow of patients through our orthopedic surgery suites, reduced wait times, and increased the appropriateness of those patients who are actually awaiting surgical consultation. But some approaches to bottlenecks cause more problems than they fix. As many of you know, Vancouver is ground zero for a legal challenge that threatens to undermine the very foundations of Medicare, namely that access to care be based on need rather than ability to pay. The owner of a private for-profit surgical center has sued the government of British Columbia and the Ministry of Health in hopes of making it legal for patients to buy their way to the front of the line. And for several years now, a number of BC surgeons have been operating in private for-profit surgical centres, unlawfully treating those who can afford to pay ahead of those who can't. This kind of innovation threatens the social contract we all have with each other, which is about implementing improvements to our healthcare system that benefit all our patients. The fact is that the innovations we need in our system don't require that we turn our backs on our values, and many of them aren't high-tech or sophisticated. They don't always involve more. They can be as simple as a single phone number where there used to be many, or as obvious as the better use of teams so that surgeons aren't the rate-limiting ingredient in access to care. And if we use evidence to address challenges like wait lists and rigorously evaluate changes that we make to see if they're working, we can ensure that any new investments are well spent. This brings me to the last idea, and to a patient in my practice we'll call Leslie. Leslie suffers from severe asthma. She takes multiple puffers, and she's been on and off prednisone, which is a powerful anti-inflammatory drug with significant side effects, many times to try to control her symptoms. She's been seen by multiple specialists, and she's been in and out of the emergency department dozens of times. Leslie's asthma started when the social housing unit she lives in had a flood. Mold grew inside the walls of the building, and her health began to deteriorate. She took pictures of the mold and she showed them to her landlord. Her doctors, including me, wrote letters of support begging them to find her another unit or another building to move into. It took her and us 2 years to get the system to respond. During that period of time, her physical and mental health deteriorated. She became depressed, unsurprisingly. Her relationship fell apart. She wasn't able to hold down a steady job. She was coughing so much. She gained weight, and her blood pressure worsened because she couldn't exercise due to her breathing problems. As my colleague Dr. Ryan Miley would say, Leslie isn't sick with asthma. She's sick with poverty. She is sick with a lack of access to appropriate housing, decent food, and the basic human dignity that comes along with being able to make the choices we all want to make to stay healthy. The third idea I want to talk about is a proposal that can be explained without even a passing reference to healthcare. Yet acting on it would do more to improve the health of the country than any single other policy that we could support. Decades of studies have demonstrated that as important as healthcare is, it does not play the primary role in determining whether or not people will be ill or well. Social factors, like the ones that led to Leslie's illness, have a much more powerful impact on the most meaningful outcomes. Income is the strongest predictor of health. Low-income Canadians are more likely to die earlier and to suffer more illnesses than Canadians with higher incomes, regardless of age, sex, race, and place of residence. So addressing poverty is one of the most important things we can do to improve health. Dr. Gary Block at St. Mike's Hospital in Toronto often quotes one of his patients who once said to him, "Doc, if you want to make me better, get me more money." And that is idea number 3, a basic income to bring all Canadians up to a decent standard of living. Basic income is a well-developed approach to reducing poverty by using the tax system. It's pretty simple. Every year you file your taxes. If you fall below a certain level, you get topped up to a level sufficient to meet basic needs. It's an alternative to costly and bureaucratic social assistance programs that would virtually eliminate poverty in Canada. As Senator Hugh Segal has pointed out, this is not a radical policy. In 1975 in Ontario, where I live, we had a poverty rate among seniors of 35%, most of whom were women. The Davis government at the time, the Toronto Star ran a series of articles showing seniors who were living on cat food in their apartments. The Davis government at the time implemented a basic tax-based seniors income top-up that then spread across the country and formed the basis of our current old age security program, which many of you will be familiar with. In 3 years, the poverty rate among seniors went from 35% to 3%. There are very few social policy decisions in our lifetimes that have had that kind of impact. And there's pretty good evidence that a broader population-based basic income policy improves health. In Dauphin, Manitoba in the 1970s, a basic income supplement offered to all the eligible residents in a small town reduced hospitalization, particularly for admission related to mental illness, and reduced accidents and injuries. A study done in Gary, Indiana found that families provided with an income top-up saw positive effects on birth weights in newborn babies across the entire community. Part of what makes these experiments tick isn't simply the money in people's pockets, although certainly that helps in terms of putting food on the table or paying your electricity bill. Income security means that even those families who never collect a penny know that if they were to fall on hard times, they wouldn't lose everything. And that has positive effects on the health of the entire community, not just the people who receive the supplement. In fact, basic income is very much like Medicare or any other insurance policy. We all pay in, we all hope we won't have to use it, but if we do, there isn't a humiliating process of having to prove our worthiness in order to have our medical bills paid or put food on the table for our kids. The same principles that led us to establish universal health insurance underpin the basic income: administrative simplicity, risk pooling, and the belief that access to some basic things should be automatic, a right of citizenship rather than an act of charity. Given that the Manitoba experiment was nearly 40 years ago, it's been suggested by many experts that a series of pilots should take place across the country to figure out how we would design a program like this for a 21st century Canada. We should get started tomorrow. Let me close this evening by acknowledging that almost everyone in this audience has strong views about what we should do to improve health. And it's almost certain that some of you are disappointed that I didn't mention the solution you were hoping for. There are obviously hundreds of good ideas where these three came from, and most of you are here because you believe, as I do, that Medicare is worth the investment of our ongoing collective energy. But I do think that the test we should apply as to whether or not we focus on any particular solution should be the one that I articulated at the outset, namely that solutions should actually reinforce the value of equity and that they should be worthy of the enormous importance we place on our most cherished social program. And when we set out to design those solutions, we should do so based on the best available evidence, unapologetically devoting time, energy, and resources to study the effects of our interventions in healthcare systems so that we can learn whether or not they actually work. So, no more tinkering around the edges. 20 drugs to save a nation, doing more with less, and basic income. If we start moving to do these three things, we will see substantial improvements in the health of Canadians. Canadians like Ahmed, Sam, and Leslie, like you and me. We need to take action worthy of Medicare. Let's go get started. We have a promise to keep. Thank you.
Thank you very much, Dr. Martin, for sharing three big ideas. Certainly inspiring. They seem so simple on the one hand, but I'm sure the audience has questions for you. So we now have an opportunity to engage in some discussion and for you to be thinking about your questions. There are people with microphones in the room, and I'm going to ask that you put up your hand and that we get a microphone to you. And the reason we're using the mics in part is because we have people joining us virtually as well. And I'll remind people virtually who want to join us and ask a question to use hashtag 3BigIdeas. So there is a question at the back of the room, and we can get started.
Thank you very much. Thank you very much, Danielle. That was terrific. And I love the fact that your #1 idea was the one that I wanted to talk about. I'm a pharmacologist emeritus from UBC and also on the board of the Bloom Group. And it's always interested me, for whatever reason, because it was 1955-56, why our fathers and mothers of our wonderful healthcare system did not think about the fact that what I will call universal pharmacare is really the most critical part of how we move forward. And I always told my students, and still do, that would you want to live in a country where there are hundreds of people buying medications, including a provincial government in 10 provinces and 2 territories, paying anywhere between, as you said, 1 cent to 28 cents, with big pharma and generics laughing their way to the bank on our expense? And I think that that's something that is so simple, But the question I have for you, because that was a comment,
Yes.
was, and I'm sure everybody in the room agrees with me, but the comment is, how do we get the federal program to be really universal when we have provincial programs that really run a significant amount, and Danielle, you probably know what percentage, of our healthcare system, including buying the meds? How do we get over that?
So it's a great question. And just to comment on your comment, to say that, this issue of access to affordable medication is, it's obviously not a problem that's unique to Canada, although it's not a problem that exists in most other developed countries. It's a big problem in the developing world. It's a big problem in the US. There's a terrific campaign called Access Our Medicines, based out of Vancouver here, that's doing some great work, and there's a declaration online, if you just look them up, that you can sign on to, because of course access to medicines is an issue internationally, especially as more and more of the disease burden internationally is chronic disease as opposed to acute disease. The question that you're asking about implementation, interestingly, in 2004, when the premiers met in Niagara, I think it was 2004, and someone can correct me if I've got the year wrong, in Niagara-on-the-Lake, I think it was the first meeting ever of the Council of the Federation, which is when the premiers come together without the Prime Minister. The premiers, I was there, the premiers stood up in front of the microphones, all in a line with their suits and their flags behind them, and they said, we've had a big discussion and we've decided what we think we need to do to move forward the healthcare agenda in Canada. We hereby declare that we wish to upload all pharmacare to the federal government. And the federal government said, no thanks. And that, we watched that window of opportunity open, and then we watched it close. So I don't actually think that on the issue of pharma spending, the provinces are territorial, or that the territories are provincial either. I think everybody everybody would be on board with that. The mechanics of how you would do it, I think there are, unlimited options. So you could do a national, truly national body, some arm's length body of government that would set the formulary and do all the bulk purchasing, which is sort of how they do it in New Zealand. You could simply have a national formulary and a single purchaser and then administer the claims provincially. There are really any number of ways that you could do it. And as I say, given how much the provinces are currently spending, and the federal government too, so remember, this is what the provinces and the federal government spend on pharma. They pay for virtually all the medications for people over 65 and people on social assistance. They pay catastrophic drug coverage, so anyone who spends over, let's say, 4 or 5% of their income on drugs, depending on the plan, public coverage kicks in. And they pay for private insurance for all their own public sector employees, which is a huge amount of money. Like anybody who works for government has a good drug plan, right? That's all tax dollars. So if you put all of that money together, you actually have a very large pool of funds available to finance a universal system of some kind. It's not a complete answer to your question, but I don't actually think that the resistance is at the provincial level on this particular file.
There's a question up in the front here.
Oh, he's got a question too. Go ahead.
Dr. Martin?
Yes.
We'll start here.
I wonder if you could tell me what your thoughts are. Canadians are pretty well known for not taking to the streets with pitchforks and flaming torches. How do we galvanize change in this country amongst the citizenry to say, this is not working and we need to fix it? It's a very big question, but I just wondered what your thoughts were on it.
Do you mean on pharmacare or just more generally around these kinds of reforms?
Generally, just around healthcare, wait times, pharmacological costs. How do we affect change? How can Canadians affect change? Baby steps even.
Right. I mean, I actually think this kind of thing is a good start. My own impression, because I've been doing a lot of public speaking since the whole YouTube thing, and my impression is that people are really relieved to finally have a conversation about healthcare that is positive. And part of it, I mean, of course we have problems, of course we need to address our problems, but people are sick of the rhetoric of it's not sustainable, the sky is falling, we can't possibly do this anymore. And people get excited about the idea that we could do something well, we could do something better, we could do something good. And so I actually think a lot of the impetus for engaging the public needs to not be around the negativity of the pitchforks and picket signs, and more around that how do we get communities engaged to move a good idea ahead. And my impression, although it's obviously not an unbiased sample, but my impression is people really respond to that. I've been blown away by the response to that. And so I don't know if it's letters to the editor and your member of parliament and attending meetings and joining Doctors for Medicare and doing all that kind of stuff. It's of course a combination of all of those ways that we can all get involved civically. But I actually think the key to engaging the Canadian public on these issues is to stop with the negativity and, and come forward with good ideas about how to make things better.
Great. Thank you. So there's a question here, and then there's a question here, and then here.
On the pharmacare issue, a somewhat smaller question than a national program. British Columbia has a public universal pharmacare program. It has very low deductibles linked to income. I think no one pays more than 2%, possibly 3% of their income. Covers a wide range of drugs, but not everything in the respective class. So I'm wondering, apart from the issue of how much is spent on the drugs and acquiring them by the province, you cited that British Columbia has the highest percentage of population saying that they miss taking drugs due to income. So where are the problems? So even if we had a national program with a minimal deductible, is it a matter of information, or where's the gap?
Right, so it's a good question, and I confess to not being an expert on the design of the BC program. My impression from my colleagues who do pharma policy work at UBC is that the combination of copays and deductibles in the BC system is not inconsiderable for a lot of people. And certainly in the case of Ontario, and I don't know, again, I don't know how people go about getting their drugs covered in BC, but I know that in the case of Ontario, the way that our program is structured is that our cutoff is 4% of your income, and that's determined on a quarterly basis. So you have to produce your tax returns, you have to send them in, and then you have to pay the 4% of your quarterly income as a deductible up front before the coverage kicks in. And for a lot of people, although the amount isn't a lot relative to may not feel like a lot relative to their annual income, when you have to pay it up front, it's not inconsiderable. So my understanding is that it's some combination of the amounts of copays and deductibles. I don't know whether there's a bureaucracy element as well here, but certainly that's the case in many of the other catastrophic programs in Canada. I mean, interestingly, if you look at the StatsCan data, they have shown a very steady, significant climb in the number of Canadians who are spending more than 5% of their income on out-of-pocket expenditures, the biggest ones being drugs and dental, right? And given that most of our catastrophic drug programs are supposed to kick in at 3 or 4%, really nobody should be paying more than 5% of their income on that stuff unless you have massive dental costs, right? So whatever it is that we're doing, it's clearly not working. And so the question is, how would you, the beauty and simplicity of the way that we pay for physician and hospital care is you simply show up and it's free at the point of contact, right? And so there's no barrier whatsoever to people accessing the service. Could we manage a completely copay-free, deductible-free, universal first dollar national pharmacare program in Canada right off the bat? I don't know. I think we'd have to look at it. I mean, I'm certain we could do it for the 20 or the 50 or the 100 drugs. But certainly the simpler the model of financing, the more chance that people will use it. I mean, if others have views about why it's not working so well in BC, I'd be very interested to hear them, because it certainly is surprising, given that you have a program, although it's maybe not the perfect program, that so many people continue to report they're not taking their meds because of costs.
There's a question here.
Okay. Hello? Okay, hi. Thanks so much for coming and speaking, Danielle. I'm a huge fan. And sort of building on the other question that came up, I think you're absolutely right on everything you said tonight, and also to the gentleman who was asking how we can create change. And I think you're right in terms of attending these discussions and writing to members of parliament and all those things. I also think that a lot of change, sustainable change, happens around kitchen tables. And like so many of us, I have a libertarian uncle who I'll be seeing in a month over the holidays. And just building on what you said about, you know, turning the conversation to what's working, you know, do you have any other advice for when we all go see that libertarian family member and hear various non-evidence-based ideas? Perhaps, like, how do you deal with that? Or like,
I would say drink more wine. I don't
Okay, so aside from the obvious,
just,
you know, we're not going to obviously convert all of our beloved relatives and relations to our side right away, but just in your experience, you know, what have you found that's worked? So for evidence-based conversion therapy.
Yeah, no, that's great. It's a great question. So I guess I would offer a couple of observations. The first is that my own experience about exposing one's passion is that it's good to do that judiciously. So, you know, there's a time and a place for being riled up, and it's probably not at the kitchen table face to face. No, seriously, or, you know, I think that those are, to me, that's the place where you bring the evidence, right? That's the place where you bring the data. The beauty of the pharmacare idea, and the reason why it's the first one that I pitched to you tonight, it's because it's the perfect example of a public policy where the equity and the values line up with the economics. I mean, how often is the right thing to do the cheap thing to do? It's a no-brainer situation, right? And so that's the case with pharmacare, and I think that bringing the data and the evidence to those conversations is critical, which is why, in all sincerity, I mean, I'm not just saying this to plug Doctors for Medicare, but all those civil society groups like CDM that are out there trying to put the evidence forward about the right stuff to do, those are critically important participants in the conversation, because, you know, when people say to me, well, private solutions and private pay would reduce wait times, I just print the CHSRF Mythbuster and hand it to them. You know, this is the research, this is the data, this is the international experience, here are the graphs, here are the charts. Do you still think that? And if the answer is yes, then you're dealing with ideology and there's nothing that you can do. We're not going to win 100% of the people all the time. But I do think that that's the moment where you go upstairs and print it off and bring it down, because I do think that there are tons of good advocacy groups and think tanks out there that are unapologetically values-driven, but evidence-based in the solutions that they put forward. And they're all producing really good stuff that you can use to help give you, arm you for those conversations.
Great. So I've got 4 questions on the go. One here, and then we'll go here, here, and then at the back. Thanks.
Thank you very much. Stimulating talk. I want to ask about your second idea, and I want to focus a bit on physicians. The idea of how can physicians help to reduce diagnostics and treatments. I'm imagining a draconian system where you tell a doctor, well, last year you had 10, CAT scans a month. This year we're only going to let you do 9. It's a bit draconian. I wonder if you have a little more useful ideas about that.
Yeah, for sure. And that's certainly not what I'm advocating. And this is not a death panel recommendation. Actually, if you look at the Choosing Wisely campaign that came out of the United States, it's a terrific example of how physician-led movement. I actually think this is the movement that needs to be doctor-led. It's the physicians who need to come forward and say, based on the evidence, we are doing things that we should not be doing, and we need to have a conversation with our patients. It's one person at a time, one interaction at a time. Why do I only need a mammogram every 2 years and not every year? Why do I only need a pap test every 3 years and not annually? Why? Because the evidence is that it doesn't save any lives, and you get false positives, and you end up with unnecessary interventions that can be harmful, et cetera. So you have that conversation one human being at a time, and it comes, again, from a place of evidence, not you've done 10 CTs and now you're not allowed anymore, but did you know that, high-dose radiation CT scanning is not an appropriate test for lung cancer, screening test for lung cancer, for example. And so I actually think it needs to be provider-driven, because if those messages come from government, people will always experience it as a rationing message, even when that's not how it's intended. Just a very small example, in Ontario, I don't actually know what happens in BC on this, but in Ontario, one of the results that came out of the last round of negotiations between the Ontario Medical Association and the government about physician fees was that the physicians pledged to participate with the government in making some good evidence-based policy decisions around tests and procedures. And one of the things that they chose to do was to stop paying for vitamin D testing, except for in a few circumstances where it's truly clinically indicated. Because in Ontario, we were spending like hundreds and hundreds of thousands of dollars a year on testing people's vitamin D levels when there's there's virtually no reason ever to be doing that unless unless a person has one on a list of very small conditions. But it had become sort of in vogue for people to come in and get their vitamin D tested, and it was on the blogs and the the chat rooms and the internet, and people were coming in asking for it, and physicians were randomly doing it, sometimes 2 and 3 times a year on people. Like it was just a huge amount of unnecessary, inappropriate testing that contributed no value. And it was the doctors who said, we don't want to do this anymore. And so I think it's a much more kind of retail conversation. You can't come at that with a big hammer, or you end up, as you say, with the wrong kind of draconian message. But if we don't have those conversations, we're going to end up wasting money. And the purpose of a healthcare system is to improve people's health. So if we're doing stuff that doesn't improve health, we need to have a conversation about whether that's how we want to spend our collective dollars. And the reality is, I think, most of us who practice medicine will be the first to raise our hands and admit some of the things we do there isn't evidence for or against, but some of the things we do there's good evidence against. And so when that's the case, we should be talking about that with our patients and not just ticking every box on the lab sheet.
Thanks, Danielle. I loved all 3 ideas. I want to come to the third one. I've spent much of my medical career, particularly in the latter part in public health, advocating for the eradication of poverty, and I continue to do that. And I like the idea. I mean, Senator Siegel's been hammering this one, who as I don't think you mentioned, is a conservative. Yeah. He's not even a lefty. And he's been pushing this idea, and I love the idea. I'm involved with coalitions and involved in this. When we go to speak with ministers or caucuses or whatnot and tell them, look, you've got to solve poverty. It's costing, in this province, $9 billion a year. We could solve it for $3 billion. Get a grip. But there's 2 things to happen. Whenever you come up, A, with the costs of doing that, because if we do a guaranteed annual income, it is going to cost some more money. Mm-hmm. And the other thing is people are lazy and they won't work anymore. Right. So how do you answer those things?
Sure. I mean, this is a tough area of policy because it's one of those classic ones where the spending comes from one part of government, but the savings accrue to other parts of government. So there's nothing in it for anyone in an individual department of ministry to take this on because there are winners and losers. It doesn't help community and social services if health saves money, right? So it's a tricky one, and I think that's the reason why we haven't seen it advance. I really like, and I think actually, I heard a rumor, and I don't know whether someone in the room can confirm or deny, that Justin Trudeau was talking at some public event about the possibility of doing some pilots across the country. I think that that's the way to do this. That's not an endorsement, but I just, but I think the way, so all of the studies on basic income came from the 1970s, right? And so they're old, and we don't know how you would ideally design that in this day and age. So let's try it. Pick a couple of communities, an urban community and a rural community. Do it properly. Like the Dauphin, Manitoba study was done in 76 or something, and over the period of a couple of years, and the data sat and never was analyzed until very recently. Some brave PhD student wrote a thesis and actually finally analyzed the data and found all kinds of terrific health effects on the community that received the basic income supplement. So I think the way to frame it is as research, pilots, trials, whatever word you want to use, and then the risk is smaller. And I think it's much more likely to be successful. The last thing I will say, well, maybe I'll stop there. There was a second, about people won't work. So there's no evidence, right? In fact, the evidence is pretty clear that when you give people money, they spend it on food and housing. And I mean, you guys had the Housing First initiative. You have the Housing First initiative here in Vancouver, which has been rolled out in other places across the country. Like if you give people who are low income money, they will almost always spend it on the things that you would hope and expect that they would spend it on. And when people are coping with addictions, I mean, people of all income levels cope with addiction. So if the occasional person, buys alcohol with it or whatever, so be it. There are lots of high income people who do that too. I don't think that that's a reason to not do anything. But again, pilot it and see. If you do a basic income supplement to a community and everybody stops going to work, I suppose that would be a problem. I doubt very much it would be the case, but the only way you'll know is if you actually do the program evaluation.
Right. So there's a question here. I know you got a question at the back, and I think there's a microphone here and then here.
Thank you. Is it working?
Yeah.
Oh, okay. Thank you, Dr. Martin. I'm part of the Canadian Federation of Medical Students, and I'm one of 70 medical students across Canada that went to Ottawa this past weekend to talk to parliamentarians about access to health. And our ask this year was universal pharmacare, which I'm sure you're very familiar would not only correct the cost inefficiencies of our fragmented provincial healthcare system, but also the cost inefficiencies of private health insurance and such, and of course would result in better health outcomes for everyone. But my struggle is that concepts like this, and I'm sure with some of the ones that you've shared, are not new concepts. So pharmacare has been a topic since the 1960s, and we've been talking about it, every 10 years or so it would come up again and over again. And so my question is, what do you think, can you comment a little on the barriers to kind of pushing these concepts through so that they can actually happen? I sense a lot of, other factors at play here that create barriers to this.
So it's a great question. I feel like you're giving me a plug because I'm giving a talk at lunchtime tomorrow at UBC on this exact question. Pharmacare seems like a good idea for 25 years. How come we don't have it yet, right? So what's the hold up, I think is fundamentally the question that you're asking. And the sort of reflex answer to that is to say, well, it's an absence of political will, right? Particularly at the federal level. But actually, we've seen governments come and go of lots of different stripes, and that has continued to be the case. Pharmacare is a tricky one because although we have a major equity problem around access to medications, the majority of middle-class Canadians who vote have private insurance. So most people don't experience in their day-to-day that experience of, and most voters don't experience it day-to-day. And so we have a situation that's actually not unlike the health reform conversations happening in the US. Big problems, huge problems that you can see when you take the bird's eye view. But the majority of Americans have some form of health insurance, and they don't feel that kind of burning platform of a problem. I think that part of what's been happening around the pharmacare thing, and I am as guilty of it as any advocate, in fact I did this tonight, is that we are offering up pharmacare as a solution to multiple problems. So pharmacare is a solution to absence of equity. Pharmacare is a solution to overpriced drugs. Pharmacare is a solution to absence of quality prescribing. Every problem you pretty much put up, we can give you the solution of pharmacare. And I think that muddies the waters. So I actually think at some point the community, and this is my talk tomorrow, the community of researchers and advocates who are all focusing on this pharmacare issue, we're going to need to kind of collectively pick a lane and decide what is on the articulation of the problem that we're trying to solve, and be okay with programs that might solve parts of this set of problems, but not every single one of them right away, because I think the giantness of the leap from where we are to where we need to be is big enough that people policymakers are frozen. It's a terrifying thing, right, to think about transferring $10 billion a year worth of drug expenditures out of the private system and into the public system, even if you know that on paper you'll make most of that money up. And so how can we help policymakers to see their way to doing that? It's a terrific question. It's a complex one and not one that's easily answered.
I'm doing the bank queuing, and so you are next and then here.
I'm going to stand because I'm short. I have a question and a bit of a comment first about the second part of the second big idea. No one's talked about it yet, and I think for BC, it's a really important issue, is the idea of this centralized intake. I'm a health science student at SFU, and I'm a little bit aware of how the intake system works in Ontario, and I have to say I'm a huge fan of it. I think it's a phenomenal idea. I personally am not from Vancouver. I'm from the interior BC, and over the last few years, as I'm sure most of you are aware, there have been hospital closures. And these are also in communities where there's a lot of elderly people, and when their access to care is reduced because of the number of hospitals that are available to them, and it becomes difficult for them to get hip replacements or knee surgeries or any of these procedures that could be, their access to these procedures could be resolved by having these centralized intakes in these community medical centers. I think it's a phenomenal idea, and I'm just interested in how you maybe foresee that being implemented in BC, and maybe what the barriers were into having that system implemented in Ontario, because I'm sure there's probably a few issues with the services that are publicly funded and those that aren't, and how they can cooperate in under one roof.
Whew. So it's a good question. There are a lot of issues wrapped up in what you've articulated. So just to say on the question of centralized intake, if I've portrayed Ontario as some kind of a paradise, it is not. We have centralized intake for cancer, which I believe you also have, and we have highly regionalized systems of cancer care in Ontario, which I think is pretty much the case now across the entire nation, which work by and large very well. For cardiac care, again, by and large, very well. And now for hips and knees, we've got them, and they're not perfect, but they work quite well. For the rest of access to specialty care, it's the Wild West, continues to be the Wild West. And for access to primary care, it continues to be the Wild West. We're actually piloting centralized intake to primary care at my organization, my hospital, Women's College. So patients who don't have a family physician who come through any specialty program of our hospital can be funneled into our Department of Family Medicine. And it's interesting to see how it works when you apply the principle outside of the world of specialists. So I don't think it's the answer to everything, but I do think it's the answer to some things. And to me, centralized intake, which is really the concept of a single queue, is separate from the question of rural, centralization of services in urban communities outside of rural communities. And that one is an incredibly difficult and tricky issue, because the bottom line is that we all want and deserve both the highest quality care possible, which in some parts of healthcare depends on the ability of organizations to provide a certain volume in order to make sure that the quality is high enough, and we want our care close to home. And we want both, and we deserve both, but we probably, when it comes to some things, can't have both. And I say that knowing what an incredibly difficult thing that is. There is no doubt in my mind that everybody should have access to primary care that they can walk to, and that there are lots of secondary care services that people should have in their communities. When it comes to, I'll give a really easy example at the other end of the spectrum. Like, I want my cardiac surgery to be done in an organization that does a bajillion of them a year, not in my local rural hospital. So the question is, like, how do you define the in-between in a way that works for patients, for individuals, for communities, and also allocates resources in the best possible way across the system? And I don't think anyone has figured this out. Like, if you look at the history of healthcare reforms in the UK, just as an example, the UK went through a big centralization, closure of rural hospitals. Now, mind you, the whole, the entirety of England, there's no similarity in the geographic scope, but even so, a whole bunch of rural hospitals got shut down, things were centralized in centers of excellence. New head of the NHS, I just read an article a couple of months ago, new head of the NHS comes in and says, we're going back out to the community, and they're like reopening all the emergency departments and all the hospitals that were previously closed down. So some of that stuff is, political decisions, some of it is a recognition that people, especially older people, can't and shouldn't have to travel too far for care, and yet some of that exists in tension with the need to have highly specialized services in places where you're doing lots of them, and it's like really tricky. I don't claim to know the answer.
I have 4 people waiting with questions, and so I think we'll take those, and we'll try to wrap up after that. So I've got it at the back here. Yeah.
Okay, I'm a kinesiologist and I work in occupational rehab. I'm also coming to MBA in January, or the MBA program here at SFU in January. And so I work with patients who tend to have the signs that they're beginning a chronic pain path, but they also are typically very poorly educated around what their injury is and what that means for them in the future and what their outcome could look like. Thinking about the idea of doing more with less, I'm completely on board, but I think it comes down to doctors who are not taking the time to educate and inform their patients. I really believe in everything in life. If you have an informed consumer, you have a better world. Do you have any thoughts around changing the patterns with doctors who are maybe more accustomed to prescribing medication and writing, hey, go for an x-ray or go for a test? Oftentimes the tests that our clients are getting are not changing what it is that we're doing with them to get them back to work and get them back to life.
Yeah, it's a big problem, isn't it? And I think, I mean, some of this I would like to say, and I don't mean to be facile about this, some of this is changing because the patients are just going out and getting their information themselves. And that actually spans across income levels, and it spans across you know, ethnocultural backgrounds, et cetera. I have more and more patients in my own practice who just come to me and say, you know, like, I did my research and this is what I think. And actually it's so great, as you say, to have a conversation with an informed consumer. And I think the days of thinking that the only place that a consumer can become informed is in their physician's office are gone. Even if we wanted to centralize the expertise in our offices, we can't anymore. And I learn a lot from my patients who do that stuff. So that's all very well and good. What you're talking about, though, I think is slightly different, which is that sometimes, and I say this, you know, I'm sure other people in the audience can relate to this, sometimes it is easier to reach for the prescription pad or the x-ray requisition than to look somebody in the eye and say, I think this is just how it's going to be. And so let's start talking about how we're going to manage your pain long term. Or I don't think that another opinion from another specialist is that is a very hard conversation to have. And we don't always train our physicians to have it, and it's not an on or off switch. You know, so when somebody is grappling in the stages of grief with a chronic diagnosis and, you know, wants to hold out some hope, it's really hard it's a complex human interaction. And then there are the times when we just don't know what we're dealing with, and so we prescribe stuff and order tests because it's easier than saying we don't know or going off and learning about it ourselves. So, I mean, there have been volumes written about this. And if you're interested, there is a great Health Council of Canada report a few years ago called Decisions, which is actually about the ordering of tests and prescribing in the family practice setting, looking at how much the huge increase in prescribing and test ordering in primary care in Canada, and trying to dissect some of the influences, some of the things that come to bear on that decision point in primary care. It's a really good report and worth a read. Is this something that can be solved with good medical education? Somewhat, but I feel like we put a lot of pressure on medical education to do a lot of things. It's probably better solved by team-based care. You know, I can't tell you how my life changed when we got a pharmacist on our family health team. I don't know most of the stuff that my patients need around being educated consumers when it comes to their drugs. I don't even know what color the pill is, or like, you know, what the long list of side effects might be or whatever. So being able to work in a team with somebody who is much more expert than I am is such a gift. And I think that is probably how we're going to get our consumers more educated, not by, we can't let physicians off the hook, but we can't expect that all of that is going to happen in the course of a 15-minute interaction in a doctor's office.
Hello, thank you very much for this. I'm Joe Blackmore, and I own a publishing company. And we've published quite a few educational books. Our one that's coming out soon is A Road to Recovery Following a Motor Vehicle Accident. So it's education. But that's not why the question I have. When a person, a doctor, wants to prescribe help psychologically, they have to either give a pill or they have to send them to a psychiatrist, and if they're poor, you know, they can't afford to go to a psychologist. Now in Australia, I understand psychologists are supported by Medicare. In British Columbia, they're not. I don't know what the situation is in the rest of Canada, but I sort of feel like there should be something for the brain that's analogous to massage therapy and chiropractic support for people. So would you have a comment on that?
Yeah, it's a great point. So this is another relic of the history of our healthcare system, right? So for reasons that are complicated, the Tommy Douglas government picked hospitals first. Like first in Canada, we had universal insurance for hospitals, and then we added on doctors, and then we sort of stopped. And while everybody else was continuing to add coverage as we came to learn what works to improve the health of the population, we just stuck with doctors and hospitals. So now we have massive inequities in access to pharmaceuticals, to dental care, to non-physician health providers of all kinds. And in fact, you know, in many provinces in the country, we've been moving backwards, delisting things that we used to cover outside of physician and hospital services. So I agree with you. It's a huge problem. And actually, ironically, you know, someone said to me the other day, I think we should teach cognitive behavioral therapy in high school. Like it should just be a course that we offer everybody in high school, or mindfulness-based stress reduction, like some, you know, basic tools for self-management and self-regulation. Actually, that should be universal. We all could use it. So why are we in a situation where we have to send people to the most expensive place in the healthcare system, a physician, a psychiatrist, when actually they would probably get, you know, a whole lot out of, and perhaps in some circumstances more, out of an interaction with a non-physician mental health professional. You know, there's been, I don't know how many of you read Out of the Shadows, the report that came out of the Canadian Senate on mental health. I think there is a growing movement in Canada around access to mental health services. It would not surprise me if we began to, so we're now seeing provinces, for example, covering dental for kids, low-income kids. We may start to see more movement in that area. I agree with you, it's a huge need, and I don't think it's based on some great body of evidence. It's just a historical relic of the way that the health system evolved in Canada.
So thank you for the talk and sharing the 3 ideas. I work for Heart and Stroke Foundation, and I'm doing my master's in healthcare leadership. I find your 3rd story very intriguing. So the part where you actually took the initiative to speak with the patients, landlords, and trying to get that issue sorted out. And I've also been following a few TED Talks where they have initiated this idea of combining healthcare with certain aspects of social care, so merging that together. In the States, they have this idea where the doctors take an extra step to ask, rather than asking how are you feeling, asking them how's your income, do you have a steady income, and so on and so forth. So what are your thoughts in terms of combining that? Because when I speak with my classmates who have been providing healthcare for 15, 20 years, they always think that it's too set in and it's too innovative or too out-of-the-box creative where they can't merge everything together. So I'm just wondering what your thoughts are on that.
Yeah, it's a great question. I mean, I think that there is lots of interesting work going on in Canada on this front, particularly in primary care. So Gary Block at St. Mike's in Toronto has been a national leader on this and has developed a really terrific tool that primary care providers can use in their practices for screening for poverty. And it's actually not that radical. I mean, it just involves saying to somebody, are you able to make ends meet? at the end of the month. Like, it's a single screening question. It's not very hard to do. And it turns out that a lot of the income supports that our patients have access to, they're not accessing. Back to this question about why do people not access the services that are even available to them? Because often, for example, low-income people aren't filing taxes, and so they don't even get their GST rebates or any of the other stuff, you know, checks that they could be getting in the mail if they went through that. But you wouldn't know if you didn't ask the question. So I think that there is work happening, and I don't think it's too far off from the day-to-day work of primary care providers. Like, almost all of us think to ask the question, do you have insurance, before we reach for the prescription pad. Almost all of us, you know, we may not always remember to ask off the bat, but nobody bats an eyelash if a patient comes back and says, I didn't do this because I couldn't afford it. Everybody understands what that means. I think the difficulty is not at the individual level. It's at thinking about how do you get health and social services to better interact at the level of the system, right? So there's some interesting experimentation going on in Ontario around this concept called Health Links, which is about getting health care organizations and social services organizations that provide care in a neighborhood, like to the same people. Imagine what a radical concept that you would get those people in a room together and start talking to each other when people are accessing, you know, housing services, support services, translation services, healthcare services, all usually within a few blocks of each other. It turns out that a lot of those people never even meet, you know, wouldn't recognize each other on the street, even though they're providing services to the same population. So I think at the neighborhood level and then at the system level, there is much that we could do to better integrate health and social services. At the provider level, I'm not saying we're any good at it, but I don't think it's all that big a leap.
So we have a last question over here.
I timed that well. Thank you, Dr. Martin. My name is Paul Gallant, and on behalf, first of all, of the Canadian College of Health Leaders, I'd like to congratulate you on your presentation, and we're very pleased to be part of that. So my question I've rewritten 3 times since you started talking and responding to your last question. I think this is an easy question. One could argue, I think, with evidence that the Canadian health system is not really a health system, but Medicare certainly is the goal. However, how do we affect the change in your 3 big ideas when we have political, the political input is really based on short-term and not long-term political election cycles? So is it possible to implement these 3 ideas in the current political landscape from a national and provincial point of view? That's our simple question. Thank you.
That's an easy one, right? We'll wrap that up in 30 seconds. So I guess I have maybe a slightly different view about the role that politics and the political process play in decision making, which is that I think politics is really legitimate. Like, you cannot, I've been here arguing for evidence, and I'm all for evidence and that kind of stuff, but we wouldn't actually want to live in a world where the only input to policy was evidence. There are other legitimate inputs to policy. Our values are a legitimate input to policy. Feasibility is a legitimate input, and politics is a legitimate input because we live in a democracy. So we elect these people to represent our interests, and they answer to their constituents. And so if they don't want to close the rural emergency department because the constituents are going to freak out even though it only ever sees 1 person a year or whatever, like, they got elected. And so I don't actually, I try to catch myself because sometimes it does feel so short-sighted, and sometimes we all experience decisions that feel highly political in nature and at odds with what seems like the right thing to do. But I think we need to, I'm not saying that you were doing this, but I think that we collectively need to welcome the political input into the process instead of always pushing back and always assuming that it's short-term or always assuming that it's, you know, lowest common denominator kind of thinking. It's one of many inputs. So to me, to answer your question, how do you actually achieve the change? You have to figure out how to align the values and the evidence and all of those other inputs with the political interests, instead of viewing the political interests as being in opposition to. And so that's frankly why I'm out here peddling 20 drugs to save a nation as opposed to universal national first dollar coverage pharmacare, because I feel like, you know, I feel like there are certain interests in the system that are more likely to align and get us to where we need to be on pharmacare with that particular approach. So I think the answer is rather than digging in our heels and saying, well, this is the right thing to do, it's the evidence-based thing to do, like why no political will, instead to kind of say, well, what are the interests of the politicians? What's the win? What's the 4-year win? I mean, do we have to insist that they take a 20-year horizon, or could we not come up with some variation on the policy that would allow them to also get reelected? It's like a legitimate thing for them to want to do, get reelected. So I actually think that that is the way forward on some of the change around these big ideas, is to try to frame the positive change in ways that align with all of the, or with as many of the interests in the system that you can. And I suppose that would open me up to criticism of being too much of an incrementalist. But I sometimes don't feel like an incrementalist. I feel like a radical. But actually, I think that's the way to do it. Thank you.
Well, that's a great optimistic note to end on. I do have a few little housekeeping things before we thank our speaker. First of all, for all of you who do have libertarians in your family, a recording of tonight's presentation will be available on the SFU Public Square YouTube channel. So over the family holidays, you can gather around and watch this YouTube presentation and have a discussion in your homes. I think that's a terrific idea. This has been a great, great evening. I want to thank the audience for participating. We've had some terrific partners on this event, and one of the partners is the City of Vancouver. So I'd like to now call upon the manager of the City of Vancouver, Dr. Penny Ballum, to thank our speaker.
Well, what a privilege. I just have to tell you, I was sort of doing the math of how many years it is since I graduated from medicine. So it's 38. And during those years, I've done pretty well everything. Been a practicing physician, a health administrator, a deputy minister, fired, a private consultant, and a city manager. And some days I kind of think of myself as I'm the primary care physician now for City Hall, because we're still working on a family doctor for everyone here. But you know, I just want to say, Danielle, like I'm kind of choked up, because just listening to you, to see a young physician touch on like what's taken me 38 years to figure out, that you have to have respect for everyone in the healthcare team. You have to understand our public and be able to relate to them and ask them very basic questions about, are you living alone? Can you put food on your table? Are you worried about your kids? Do you ever get outside? Can you get to your community center? Can you ride the bus? Like those really basic things that, you know, I think some of us who've been around feel are being lost from the art of healthcare and medicine. But, you know, just to hear you just so cleverly and articulately talk about, you know, how to impact elected officials and respect their job, which is a really tough one, and get in their frame and their paradigm and figure out, well, how do you catch them and get them to focus and actually make a commitment and follow through on it? It's really, really wonderful. So I just want to say, from my perspective and on behalf of all of us here and the citizens of Vancouver and British Columbia, we're very lucky to have someone like you leading the way. It's a really, really important agenda. I think you have a lot of support, and if you carry on being able to talk about it in such a focused way and giving real life examples with real names of your patients that everybody can relate to, well, I think there is real hope for our Medicare in Canada. So thank you so much.
Thanks.